Hello and welcome. I'm Dr. Daniel Call, and on behalf of CME Outfitters, I'd like to welcome you and thank you for joining us for today's educational activity titled CMV Prophylaxis in Kidney Transplant, Examining New Solutions to an Old Problem. Today's program is supported by an independent medical educational grant from Merck Sharp and Dohme Corporation, a subsidiary of Merck and Company. So to introduce myself further, I'm the Director of Transplant Infectious Diseases at the University of Michigan in Ann Arbor and the Director of our Infectious Disease Training Program. I'm very pleased to be joined today by an excellent panel who I'll ask to introduce themselves now.
I'm Roy Bloom. I am a professor of medicine at the University of Pennsylvania's Palmer School of Medicine. I'm the medical director of our kidney and pancreas transplant program as well at the Hospital of the University of Pennsylvania, and it's a pleasure to be here.
And I'm Margaret Jorgensen. I'm a clinical pharmacist in abdominal solid organ transplant at UW Health in Madison, Wisconsin, and the program lead and creator of our CMV antiviral stewardship program.
Great, thank you. So before starting our program, I want to express, my excitement at how unique an opportunity is to be on this panel. We, the three of us, represent different backgrounds, different roles, and different institutions. And really, we look at the topics being discussed today in a different way. And we know that everyone may do things a little bit differently based on the capabilities of their centers, their immunosuppression protocols, and other factors when it comes to CMV prophylaxis. So we really hope that this discussion can help provide you with a well-rounded perspective when it comes to CMV prevention and provide you with something unique to take back to your practice, no matter what role you work in. That's being said, let's look at our first objective of the day, which is to identify the current implications of CMV infection in kidney transplant recipients. And we'll start with Dr. Jorgensen by taking a little time to tell us what CMV is and why it matters in practice. So, Dr. Jorgensen, could you start talking about this subject?
Yes, thanks, Dr. Call. So cytomegalovirus, or CMV, is a ubiquitous herpes virus that causes primary infection followed by lifelong latency. So it's important to know that we're going to talk about a lot of antivirals and, prophylaxis treatment, but there is no cure for this virus beyond, the host immune system ability to maintain the virus in latency. So it's quite prevalent in North America. 50% of adults are infected by the age of 40, but most of the time you get infected in childhood, and really you don't even know you got CMV. Tends to be asymptomatic in immunocompetent people. However, in the setting of immunosuppression, like after a transplant, it can have severe manifestations.
So, Dr. Jorgensen, we know CMV is a virus that can cause these complications, as you mentioned, in immunosuppressed patients. Could you drill down on that a little bit and tell us what these complications tend to look like?
Definitely. And I think, we should probably review a little bit of the nomenclature before we get any further into it. So we'll refer to something called primary infection. So this would be an infection that occurs in a seronegative patient or someone who was never exposed to the CMV virus before transplant. And now after transplant, they're having, their first ever infection. We'll also talk about reactivation, which is recurrent viral seeding of the blood in a patient who had been exposed to CMV prior to transplant and should have pre-existing immunity. We also, when talking about CMV disease, classify these into two separate categories. So there's CMV infection, which really just refers to viral replication in blood and tissues, irrespective of symptoms. And then there's CMV disease, which could either be viral replication or end organ manifestations in the presence of symptoms. So the most common symptoms are fever, malaise, and leukopenia, and this is referred to as CMV syndrome in the presence of viral replication. There can also be end organ manifestations, most commonly to the GI tract, CMV colitis, gastritis, or esophagitis. The CMV virus also tends to have a predilection for allograft tissue. So if you've had a liver transplant, you're more likely to have CMV hepatitis with elevated LFTs. If you've had a lung transplant, you're more likely to have CMV pneumonitis and so forth.
Great. Thanks so much for that discussion. And let's take a second here for an audience response question. And the question is, which patient population of the ones you see listed below is at the highest risk for CMV infection? Please go ahead and vote, and then we'll discuss your results in just a minute. Great. Thanks. So, Dr. Jorgensen, maybe we could just kind of discuss, as relates to that question, serostatus and level of risk.
Yeah, that sounds good. So, risk of CMV is evaluated based on serologies done at time of transplant. So this would be, had you been exposed to the virus before transplant or not? So the lowest risk patients are seronegative recipients. So they were never exposed to CMV prior to transplant, and neither was their donor. So there's no CMV in that picture. We anticipate that they won't have CMV disease. Of course, they still could be exposed in the community. Moderate risk are seropositive recipients. So this is a transplant recipient who previously was exposed to CMV prior to transplant, should have pre-existing immunity, and then their donor may or may not have been exposed. But the highest risk are these seronegative recipients. So they've never been exposed to CMV, they have no pre-existing immunity, and then they receive an allograft from a seropositive donor. So in the allograft is latent virus, and we essentially know that we're giving these patients who have no pre-existing immunity the CMV virus. The reason
Sorry, I didn't mean to interrupt you. Please go ahead.
I was going to say the reason why it's important to evaluate risk at transplant is because despite the presence of these potent antivirals that we'll discuss later in the presentation, CMV disease still has pretty significant effects on the graft survival. So, it's associated with rejection in this study. It is also associated with increased length of hospital stay, hospital readmission, and increased costs. So despite having these drugs to treat it, it still, is a problem in this modern day.
Great. So fair to say CMV is bad.
Agreed.
All right. I think we can all agree on that one. All right. So let's move back to our original audience response question and see what we learned to answer this question. Which patient population is at the highest risk for CMV infection? Okay, so what we see, so there's pre and post, and as Dr. Jorgensen explained, the highest risk is donor positive, recipient negative. So folks, as you stated, who are, we're giving them a good thing in the organ and often a bad thing in the CMV. And so you can see there was, you communicated that very well, because we went from 29% pre to 74% post. So let's move on now to objective number 2. And thank you so much, Dr. Jorgensen, for a great start to the program. In this section, we'll turn to the second objective, which is to develop an evidence-based, individualized plan to optimize CMV prevention for kidney transplant recipients. So we'll move to Dr. Bloom. And Dr. Bloom, really to understand CMV prevention, we have to be familiar with the strategies that are commonly used, meaning either preemptive therapy or universal prophylaxis. And Dr. Bloom, can you introduce us to those concepts?
Sure. Thanks, Dan. So, of the two strategies, there is either the preemptive approach or PET. What this entails is weekly CMV nucleic acid testing monitoring for at least 12 weeks following the transplant. And then once a predetermined viral assay threshold is crossed, antiviral therapy is begun. Now, there's no current universal threshold that's defined for this. Different sort of thresholds have been published, often around 1,000, but that remains to be standardized on a universal basis. Besides the preemptive approach, there's also universal prophylaxis. And in this context, prophylaxis is usually given within 10 days post-transplant. The duration of the prophylaxis varies. It depends on the serostatus of the donor and recipient. So, for example, patients that are considered higher risk would get a longer course of it, whereas patients that are lower risk would get a shorter course of CMV prophylaxis. And even for the seronegative to negative donor and recipient pairs, they may not even need CMV prophylaxis per se. So just to compare prophylaxis versus preemptive therapy in terms of the pros and cons, or benefits and advantages and disadvantages, using a prophylactic approach, you're treating the whole population. So it's very uncommon or rare that you'll see CMV breakthrough, and so you don't usually see early CMV. On the other hand, with preemptive therapy, you will anticipate getting a lot of early CMV that you will then take an approach with preemptively treating. Regardless, both approaches are quite effective at reducing or preventing CMV disease. Late CMV, because you're prophylaxing during the early phase, is much more common with a prophylactic approach, whereas preemptive therapy, most of the patients who will develop CMV will develop it during that period, and so late CMV is less common. Resistance is uncommon with both approaches. Clearly, a prophylactic approach is easier to implement. So I work in a large transplant center where we transplant almost 300 kidneys a year. And for us, it's much easier to just say for everybody, we're going to use prophylaxis. It would be challenging for us to implement a preemptive approach. But certainly in a smaller scale program, or if you have the resources, I think it's a reasonable alternative. Prophylactic therapy, at least with valganciclovir, will prevent herpes and varicella virus, whereas obviously if you're not using any prophylaxis, you are going to need to still consider having some kind of preventive therapy for these two viruses. Other opportunistic infections are prevented by prophylaxis. The data is less common in preemptive approaches. The cost of the drug, obviously, if you're treating everyone with prophylaxis, you're going to assume that everybody will, that cost has to be borne, whereas with preemptive, you're only paying or covering the monitoring costs, and patients who need to be treated. Overall, if you compare costs between the two approaches, there is data suggesting that if you account for everything, including developing CMV disease, there may not be a huge difference between the two approaches. Safety is always a consideration. Side effects from using prophylaxis, whereas if you limit it to preemptive, it'll be much less toxicity. Prophylaxis may prevent rejection, whereas this is largely unknown with preemptive therapy, and graft survival has not been shown to really differ between the two approaches. But as long as you treat CMV, there is a general improvement. So bottom line is, with screening for CMV using a preemptive approach, the less frequently you screen, the higher the rates of CMV, and the more likely that you'll have inferior graft survival versus universal prophylaxis. This is just a recently published study that compared a prophylactic and preemptive approach. It was a study from a single center in Europe, a randomized controlled trial, open label. included patients who were either recipient seropositive or donor positive recipient negative. Over the primary endpoint was the incidence of acute rejection. There was no significant difference at the end of 1 year post-transplant. Subclinical rejection, however, on a protocol biopsy at 3 months was a little more common or likely in the preemptive group. It was reduced by prophylaxis. Preemptive therapy had higher rates of CMV DNA, which is not surprising. But overall, both strategies prevented CMV disease. By the same token, preemptive therapy was associated with a lower rate of neutropenia.
Dr. Bloom, get a couple questions from the audience related to what you're talking about. And I don't know if you'll have an exact number for this, but the question is, what's kind of the cost for monitoring, if you know what that assay costs, at least in your center?
Honestly, I don't.
I can make a guess if you want. I think it's probably.
Go ahead.
I was going to say it's probably going to be a couple $100, something like that. Obviously what people bill and what they're actually able to collect can always vary, but that'd be my guess for a CMV PCR, but I could be off a little bit. And then one other question. If there's no universal threshold for preemptive treatment, how would we determine what the threshold should be? So, that points out one of the major problems.
Yeah, I think that's a great question. So the study that I just showed you, for example, in that trial, they used a threshold of 1,000. They did whole blood monitoring, but they used the threshold of 1,000 as their point of initiating therapy in the preemptive group. We, in my center, do prophylaxis, but what we do when patients, let's say post-prophylaxis, when they become viremic, then our own practice is to use 1,000 for initiating treatment, even post-prophylaxis. So again, that's giving you the experience of this trial in my own center. That's 2 centers, but I think that's a reasonable start. But I think that's a good point in terms of knowledge gap or unmet needs in terms of understanding what that threshold should be.
Yeah, and I'll just mention, because there's no set thing for donor positive, recipient negative. If I'm in a preemptive strategy, when I see viremia, then I'll start to treat it, because those folks don't have immunity if they're still in the prophylactic period. Well, thank you, Dr. Bloom, for your discussion on prophylaxis and preemptive therapy. There are some other questions on this that we'll get to in the question and answer therapy as well, but I think it painted a great picture as to the 2 different methods. So, Dr. Jorgensen, the rest of the learning objective will focus on some of the specific therapies used for CMV prevention, particularly in the universal prophylaxis scenario. But before we have you go through and discuss those, maybe you could talk a little bit about really what the end goal is of CMV prevention in all of these different strategies.
Yes, thank you, Dr. Call. I agree. Before I get too into the weeds with drugs, because, as a pharmacist, we just love talking about medicine, I just want to remind everyone that there is no cure. The only way the patient develops freedom for life from antivirals is to develop cell-mediated immunity. So we want to create an environment that's conducive to cell-mediated immunity. And the antivirals are really just our tools to help the transplant recipient get to this. So historically, and currently, the gold standard antiviral for treatment and prophylaxis is ganciclovir and its oral prodrug valganciclovir. These drugs were great. They really revolutionized, the immediate post-transplant period and the treatment of CMV. However, unfortunately, they do have a pretty potent toxicity, which is this neutropenia and leukopenia we've been talking about a little bit so far. So in this retrospective study of 363 mixed allograft subtype transplant recipients, where they compared patients who received valganciclovir prophylaxis to those CMV donor negative, recipient negative patients who would have received just acyclovir. They found those that got valganciclovir had significantly more new onset leukopenia, neutropenia, and required a lot more GCSF to support them. And, this myelosuppression is associated with a significant burden, mostly in as much as if you have a low white blood cell count and you're requiring GCSF, you may turn to reducing immunosuppression. So many times, especially in the high risk subset, you wouldn't want to reduce the dose of your universal prophylaxis, the valganciclovir, because that's associated with resistance. So instead, you turn to the mycophenolate because that is certainly a key side effect of that medication as well. And then any mycophenolate reduction in the first year is associated with acute rejection. So, it's not the best option to deal with that toxicity.
Yeah, that'll be a great discussion topic. So thanks for that discussion, that kind of the rock and the hard place that we get in this situation. We have another opportunity for the audience to participate with a response question. So the question is, which of the following is used for CMV prevention in high risk, so donor positive, recipient negative, as we discussed before, adult kidney transplants recipients, and is also associated with lower risk of leukopenia and neutropenia? So please go ahead and vote now. And as we did before, we'll talk about your results a little bit later in the presentation.
All right. Well, while you're thinking about your answer to that question, I also wanted to present this novel antiviral agent. So letermovir was FDA approved for prevention of CMV in high-risk kidney transplant recipients on June 6th of this year. While this medication, is similar to valganciclovir, it's available orally. Dose doesn't have to be adjusted for renal function. There are some important drug interactions that we'll talk about later towards the end of the presentation. And important to note also, this medication has a much more narrow antiviral therapeutic index. So it doesn't cover, HSV and VZV like valganciclovir would. But in the phase 3 trial, where they compared valganciclovir to letermovir along with acyclovir, they found, looking at a primary efficacy outcome of CMV disease through the first post-transplant year and a safety outcome that was a composite of leukopenia and neutropenia measured a number of different ways, they found that letermovir had a lower risk of these drug-related adverse events. So overall, there were significantly lower levels of leukopenia and neutropenia, and also it met its non-inferiority criteria. So letermovir was no different in efficacy as valganciclovir, preventing CMV replication in the high-risk CMV subset with improved tolerance.
Great, thank you. So let's move back to our original audience response question and see what we learned. So to remind you, the question was, which of the following is used for CMV prevention in high-risk adult kidney transplant recipients and is associated with lower risk of leukopenia and neutropenia? So you can see the results here, and the answer is A, letermovir. Maribavir is a drug that is approved for treatment of resistant or refractory CMV, but does not have any approval for prevention. famciclovir is a drug that's sort of similar to valacyclovir. Acyclovir does not have activity against CMV, or not significant activity. And the same is true of acyclovir. Some activity, but not some that really would be that useful for CMV prevention. And any other comments, Dr. Jorgensen and Dr. Bloom, about this?
Not currently.
Fair enough. Yeah, I guess to me, what was striking here with the approval of this drug, I wasn't at all surprised that it didn't cause leukopenia, because we've been using it since 2017 in stem cell transplant patients for prevention, but that the efficacy was quite good and there was no emergence of resistance, which was my major concern prior to this trial, not so much the lack of side effects, because we drug had been approved and we were aware of that. Okay. So
what I thought was kind of interesting about it was there was some initial hope that because it doesn't cause such severe leukopenia and maybe, doesn't suppress replication as well, that during the 6-month prophylaxis, patients would have some subclinical replication that then would result in development of CMI. But the fact that it's completely non-inferior, that means in those high-risk patients, post-prophylactic CMV is still going to occur. So you still need to be aware that just like when you stop valganciclovir, when you stop letermovir, it doesn't actually provide any additional benefit in that sense.
Yeah, that's a great point. The main advantage is clearly the lack of toxicity, with a trade-off perhaps of some drug interactions to deal with, but things that we're relatively used to dealing with. All right, so let's move on to our last learning objective of the program, which is really about implementing an interprofessional team approach, including institutional policies or protocols to support optimal use of CMV prophylaxis therapies. And for this last objective, we plan on having discussions on different topics that really shape the protocols associated with our specific institutions. And we know that all institutions are going to be different and may be in different stages of thinking about their protocols since the approval of letermovir for this indication. So I hope our discussion can provide some benefit to those who are in that process. And we're all on this panel in different stages of that process. So let's begin by talking about best practices for laboratories. And the issues are challenges in getting timely labs. And I think a lot of this would be around doing a preemptive strategy. And is this really realistic for your institution? And then how often and for how long do we order labs? Maybe we'll start with Dr. Bloom. You mentioned earlier large institution might be difficult, but maybe you could elaborate on that a little bit.
Yeah, so we're a large institution. We have patients, we get patients from, a radius of hundreds of miles from our center. And so, generally in managing these complications like CMV, we would like to have standardized lab. We're knowing that it's a plasma level and that it's in a lab that we understand and know the virology well. So I think, to have patients going to a local hospital where they send it out to a commercial lab, and it could take days or weeks, not weeks, but several days to come back. In our own center, we can usually get this done within 24 hours at the longest. So I think that's an issue, that is difficult. Most of our patients on a longer term basis beyond the first month are not coming back and forth to the transplant center to do their longitudinal labs. Preemptive therapy is therefore a little bit, as I mentioned, it's more challenging. Where we have done it, so where we've had to resort to it, say for cost purposes, because patients have not been able to have adequate insurance coverage to cover the costs of prophylaxis. Where we've used preemptive therapy, we generally use it for the duration that would we'd be doing prophylaxis. So, for example, if it was an indication for 12 weeks of prophylaxis, then we'd screen patients for that long with a preemptive approach.
Great, thank you. Dr. Jorgensen, your thoughts about some of those issues?
Yeah, so this is an issue near and dear to my heart because we have a very rural and geographically dispersed population here in Wisconsin. I mean, we're talking UP, Michigan, Minnesota, sometimes like as far away as Florida, the West Coast. And, even at my center, we do surveillance in the high-risk population after universal prophylaxis. So that would be considered a hybrid approach where you give universal prophylaxis with a drug for a set period of time and then convert to sort of a preemptive approach thereafter because of our very high rates of CMV we were seeing in the high-risk population. So whether they're near or far, if they're high risk, they're required to get these labs. And we spend the majority of our time in the CMV stewardship program calling labs, requesting labs, calling patients. And really, if there was some way to ensure that the lab would really draw it. You think that it's the patient or, some communication error, but the lab will have the orders. The patient will get the draw. The patient will say, please, will you draw my CMV? Because we call them and tell them to say that. And still they don't run it. So it is very resource intensive. And then, in a high risk patient, if you were to miss 2 laboratories in a row, so you have a 3-week gap, the patient can present with viral loads greater than 10,000 due to their rapid replication rates. So it is definitely a challenge. I mean, we love preemptive monitoring. It really is avoiding antivirals and encouraging CMI, but there is a challenge to it for sure.
Yeah, absolutely. I agree with both of you. I love the idea of it, and we know that it's been demonstrated in a clinical trial setting, at least in liver transplant patients, to result in less CMV disease over a year and better cell-mediated immunity, and that's obviously the cause of less CMV disease. But implementing it, getting the right lab drawn, the result communicated, an action taken on that result, the medication obtained and started it's a huge challenge for preemptive monitoring, particularly in larger programs. Great. So let's move on to the next discussion point, which has to do with different serostatus groups and the choice of therapy, whether they're high risk, so the donor positive, recipient negative, moderate risk, which is recipient positive regardless of donor status. And then the category that sometimes scares me the most is the low risk, who are negative. And Dr. Bloom, do you have any comments about the choice of therapy in these different groups?
So we typically use prophylaxis for 6 months in the high risk group, 3 months in the moderate risk, and then in the low risk group we just use valacyclovir for herpes and for herpes prophylaxis. Up until now, we've largely been using valganciclovir. We've used letermovir in a few patients. I know there's a question in the chat about valacyclovir. We've used that on very few occasions, again, usually related to insurance and co-pays for patients. The main issue there, I think, is the pill burden, with the valacyclovir. But we typically have been using valganciclovir dosed for kidney function.
Great, thanks. And I don't want to be cryptic there when I said the low risk scare me the most, because low risk shouldn't scare you. The reason it scares me is because every year I get a person where, and this is a known problem, where the serology on the donor is incorrectly negative. They just have cleared their antibody or had it a long time ago, or a technical problem with the test. And then this person is unprotected. And actually, Dr. Jorgensen, I thank you. You fixed this problem for us, because we're going to start doing CMV PCRs in all these people at about 3 or 4 weeks so that we don't miss this problem. So I appreciate that.
Sometimes donors get transfused that we don't realize, and they could be transfused even if they were naive, they get transfused with CMV tainted blood.
Yeah, and there are studies that do CMI assays in people who are seronegative and are positive, which shows that they had CMV before. It's actually a potentially more sensitive test, or at least it picks up a different population. Yeah, and I think I'll just mention in our center, we're very similar to where you are, Dr. Bloom, which is we do the 6 months in the high risk. And even if they get induction immunosuppression with something like thymoglobulin, we still do 3 months in the recipient positive and just something for herpes simplex and varicella zoster in the low risks like acyclovir 200 twice a day or Valtrex. And we're also use letermovir right now. We're sort of moving into it in patients in whom there are problems associated with valganciclovir, which we'll be talking about later. Dr. Jorgensen, I know you are in a different place ahead of us, probably. Maybe you could talk a little bit about what you're doing.
Yeah. So, yes, definitely screening surveillance PCR. Can't recommend it enough. It just takes the edge off on those neg. You have a single misclassification and, you pay for that for 1 to 2 years even to get them to clear it. And then the outcomes are terrible. So yes, 3-week PCR at their surgical follow-up and you're set. But, yeah, so at my center, it was the same. We gave 6 months of valganciclovir to high risk, and we gave 6 months of valganciclovir to moderate risk if they, had lymphocyte depletion, and everybody got quite leukopenic and it was horrible. And then we had to pull them off of it and put them on preemptive monitoring. And we already talked about all the troubles with that. So, early on, we were using letermovir as a secondary prophylaxis agent, which of course is off-label. So we had some familiarity with it, and we're like, this is great. I mean, no leukopenia. You don't need preemptive monitoring. And, with the stewardship program, anything that makes our job easier, like not doing preemptive monitoring, is good. So we were really aggressive with updating our protocols when it was FDA approved to make letermovir our workhorse agent. So all patients of all serostatus, besides, of course, low risk, who still get acyclovir, will get letermovir on post-op day 1. You have to be cognizant of the drug interaction with tacrolimus. So it was very important to start it while they're inpatient after their transplant to account for, the effects it'll have on their tacrolimus. And then we continue it for 6 months per our original protocol. It is challenging to obtain it through insurance. You have to be really proactive. We're doing test claims, while they're in the operating room. Everyone requires a prior authorization. Many people require an appeal. And, in the high risk group, we do everything possible to get that patient on letermovir because we want to preserve the lymphocytes, for their surveillance phase when we have about 50% have a replication event.
So in exchange for all the work you put in up front and early, then you don't have to deal with all the work that's associated with really our next topic here, which is the leukopenia that we see so often, and that is often where Valcyte or valganciclovir is often a major contributor. So I think that's really what this gets at. When do we start prophylaxis? When do we discontinue prophylaxis? And I guess we can start with Dr. Bloom. What are the things you encounter? You're mostly using valganciclovir, whether it's cost or side effects that makes you have to come off that.
So 2 things. We typically, we use RATG in most of our patients. We use MMF at a 500 milligram twice a day dose. So we don't use higher doses of MMF or mycophenolate sodium. And then we use 450 milligram of valganciclovir for intermediate risk. And I mentioned earlier the 900 milligram for the high risk. And so, one thing that we have known in our program, and it is a challenge, but for patients that are high risk who develop leukopenia, we never reduce the dose of the antiviral prophylaxis. So We may reduce MMF, we may hold MMF, we may increase, TAC or prednisone even a little bit, but we do not reduce or if someone's on a steroid withdrawal, or steroid avoidance, we may start them on a bit of prednisone, but we never reduce valganciclovir because of the concern of developing CMV, and you're basically converting them to a preemptive approach, and potentially putting them at risk for CMV. And while I do understand the benefits of potentially getting CMI, you have to weigh that up against the indirect risk of having rejection in patients who do develop CMV, as was shown in that study that I presented. So in patients who get profoundly leukopenic, we typically resort to using GCSF. We obviously we're used to it now, but it can be discomforting, and clearly if we could avoid having leukopenia, there's an advantage to that.
Dr. Bloom, on behalf of your Transplant ID colleagues and pharmacists, we appreciate you not reducing the dose of valganciclovir, so we don't have to get a 4:30 on a Friday drug-resistant CMV. So thank you. I know you're not using the valganciclovir as much anymore, so I don't know, Dr. Jorgensen, if you have anything to add to that.
Oh, well, certainly, because we don't have 100%, coverage through insurance. So patients certainly do need valganciclovir sometimes. And unfortunately, there are some high-risk patients that, they're over income for the patient assistance program through Merck. Their insurance copay is like $6,000, the price of the drug. So in those, we're not going to force them to buy it when their valganciclovir is like $300. So typically, we try to get people at least 90 days. So we're talking pre-impact duration. Because of an experience we had with de novo PEM in these high-risk patients, where it seemed like because of their lymphocyte depletion, they really couldn't mount CMI in the first 3 months. So all the replication events, weren't helping them. They were only hurting them. So we tried to get them to 3 months, at least 2 months. But if they do become leukopenic at that point, we will convert them to high-risk PEM with weekly CMV PCRs. We also have started to run into an interesting issue with letermovir that you don't really see with valganciclovir. So typically you would give 6 months. And when telling the patient when to stop the drug, you're like, okay, it's June 6th, stop it on December 6th. But letermovir is dispensed in like a dose pack where you take 28 days. So there were some growing pains with like dispensing it in time so they didn't miss any doses to be on this like every 28-day schedule. And we often after the 5th dispense, we'll call the patient and say, well, how much drug do you have left? We need to figure out exactly when you're going to stop it and cancel the script. There's no point of having any leftover letermovir lying around. You can't use it for treatment. So it's best to just finish up the pack and then, do all the tacrolimus adjustment and that sort of thing. So yeah, you learn and grow with these new drugs and new protocols.
Well, that is a great segue. You mentioned the tacro interaction. Maybe you could just touch on how you manage that interaction we obviously have with letermovir, but do not have to deal with valganciclovir.
Right. So I like to think of letermovir as more, it's kind of like fluconazol's drug interaction, but it seems to have a quicker onset, about 3 to 5 days versus a week. So we do an empiric 50% dose reduction when starting letermovir, and then double the dose when stopping the letermovir. It's a little tricky if you're doing it on the inpatient setting because if you're getting daily tacrolimus levels, you won't necessarily see the full effect for a couple of days. So in that setting, you might want to just monitor. But in the outpatient setting where you're measuring time based in weeks and not days, you definitely want to empirically adjust with its initiation. Now, I just want to put in the caveat for my cardiothoracic transplant friends. If the patient is already on very potent CYP-mediated drug interaction kind of drugs like posaconazole, prophylaxis, it is possible that such an aggressive dose reduction is not required because, at some point you've just saturated those enzymes and you really aren't going to have a bunch more drug interaction happening. So
that's a very good pro tip. In the interest of time, I'll just mention this myself around HSV and VZV prophylaxis. But before I do, I'll make a shout out for Shingrix to get your patients. It's approved for any adult. They don't have to be over 50 if they're immunosuppressed or if they're about to become immunosuppressed. And we haven't had troubles at all recently with payment, but that's a great way to prevent some of the varicella zoster that you'll see after immunosuppression. But it's just, we put this in there just to remind people that unlike valganciclovir, letermovir does not have activity against herpes simplex or varicella zoster virus. So really, you have to add either acyclovir or Valtrex if they're on letermovir. And then cost. So this is a big one regarding the difference between valganciclovir and letermovir. Dr. Bloom, I don't know if you have any comments. Dr. Jorgensen had mentioned they do the test prescription and other things early, but whether you've had issues with getting letermovir covered.
So in the few patients that we've used it in thus far, we have not, but I know that it could be an issue. We've had issues over the years with valganciclovir. It's costly. So, in general, when we have our financial coordinators try and anticipate these costs prior to the transplant.
Yeah, Dr. Jorgensen, I don't know if you had anything else to add, regarding manufacturer programs or other avenues that you've used in your patients to help get letermovir covered.
Right. So I just want to mention one thing quickly. Valganciclovir is still quite expensive. And the old patient assistance program that used to be available through Genentech has termed. So for the past year, that was no longer an option. And actually, that was a really great patient assistance program. It was easy to enroll in, and many patients would qualify. So we sort of started pivoting to letermovir last year when that ended. And I always try to remind coordinators and, the transplant team, if somebody can't afford Valcyte, preemptive treatment, the PEM approach is not great because you have to look at their risk for replication. So if they're high risk and you put them on PEM because they can't afford Valcyte, well, are they going to be able to afford treatment dose? Because 1 in 2 chance that they're going to need it. And then, the seropositive group in our data, we found that it was about 35%. So you're playing a little roulette with that. I mean, maybe you wouldn't have to buy it when you left the hospital, so you could save some money for your $200 prescription. But the cost is really tricky. Certainly taking someone off Valcyte prophylaxis when they have leukopenia, like sure, we'll use the Valcyte if we have to. But the cost is tricky. And unfortunately, the patient assistance program through Merck is a lot more challenging than the old Genentech for Valcyte was. I mean, you have to obtain their income. They have to sign multi-pages of paperwork. They have to bring in a 1040 form that proves their income. They have to send in copies of their insurance cards. So it's funny because Merck has a great patient assistance with posaconazole, but for whatever reason, this letermovir one is a little bit trickier to get access to. So, we have a team that kind of does this investigation of benefits, but the pharmacists actually started taking it into our own hands to get these papers signed and things to try to move the process along, because we like to think, this valganciclovir exposure puts the patient at risk for some resistance, according to the guidelines, any exposure longer than 6 weeks. So, any exposure we can avoid by getting them this alternative agent that can't be used for treatment is worthwhile. And, we don't want them filling the valve site 3 times and then switching to letermovir, because you've sort of lost that benefit in that case. So all I can say is, a really proactive approach, and know that all the work you're doing up front will help you on the back end, but it is a lot of work.
Well, thanks so much. That was really great practical advice. We have in the information that's available for our participant or viewers and participants. We have these top 10 commonly asked questions. Many of them go back and reinforce the points that we've already made. So to make sure that we have time for questions, we're not going to go through and specifically discuss these now, but they are available. And what we'll do is go ahead and start to answer the questions that are asked. So let's take a few of those. Dr. Jorgensen, I'll send the first one to you. Do you have to adjust letermovir if the patient is on Bela?
You don't ever want to really adjust the letermovir. It would be adjusting the tacrolimus. So the letermovir dose, it's a pharmacist's favorite drug. You don't have to renally dose it. The dose is always the same, 1 pill a day. It's not too big. It's great and all that in that way. With belatacept, I would say if they're CMV high risk and it's like a, de novo belatacept post-transplant, maybe do a little CMV monitoring, because the only case of letermovir failure that we've ever seen was in the setting of belatacept induction with low-dose TAC and mycophenolate and pred, so a quad therapy kind of setting. So you just don't want your prophylaxis to fail when you already have this kind of high-risk scenario going on. But
I would just say that, there's actually a few studies now that show that belatacept can be associated with quite severe CMV and refractory to therapy CMV. So that's not a reason to not use letermovir, but I endorse that you need to monitor CMV closely in patients who are
high risk. Yeah. Yeah. Seropositive, we've had someone on preemptive monitoring and they'll replicate and then they come back down. You got to love that pre-transplant immunity.
Great. Thank you. Another question here. We've been focused, and the clinical trial obviously was limited to high risk, donor positive, recipient negative for the licensure of letermovir, which, if I recall, came like the same day the trial was published, which was kind of amazing. But the question is around moderate risk patients and whether or not you use letermovir for moderate risk patients. And as a side to that, whether there are more challenges for payment since it's technically not FDA approved for moderate risk.
Yeah, so far, no. But I am a little concerned. Usually in the first 6 months or so, after it's approved, it's kind of like a free-for-all. At least this is what we experienced when it was FDA approved for BMT. We were able to get it for a lot of people after solid organ transplant because the insurances had not reviewed the formulary yet and created any limitations. So I'm a little concerned in the new year if we might get a lot of denials for the seropositive group. But to date, we've been able to get many seropositive patients on it, and it is just dreamy. You want to get rid of preemptive monitoring for those toxicities. Letermovir definitely solves that issue.
Right. And, we talked about this one a little bit, but maybe to just discuss again, and that's how do you manage viral resistance? Maybe I'll go ahead and take a quick stab at that and see if others want to add anything, which is one of the nice things now is that in the past, all the drugs we had for CMV basically worked at the level of the viral DNA polymerase, right? And so while you didn't always see cross resistance, you could even get cross resistance between valganciclovir, cidofovir, and foscarnet. But the nice thing about whether it's maribavir or letermovir is they both have different and unique mechanisms of action. So you don't see cross resistance between those two agents. So in terms of how we manage viral resistance, what I would say is that the drug that's approved, that has FDA approval for resistant or refractory disease, is not letermovir, it's maribavir. And I would say that's an option, but I would also mention that people with very high levels of viremia or very significant end organ disease, you may not get what you want out of maribavir, and you definitely have increased risk of resistance with either maribavir or letermovir. So when we can, we try and use something like foscarnet, which obviously has toxicity issues, to bring down the viral load and then start them on maribavir. I don't know if Dr. Jorgensen or Dr. Bloom, if you have any comments about that. I know, Dr. Bloom, that's getting to the let the ID people deal with that issue, but
that's more or less what we do, but I agree with you.
Yeah. Well, I certainly, that is an issue near and dear to my heart, because the best resistance is no resistance. And I can't say this enough. If you can be proactive, if you can monitor these patients before any problems develop and prevent them from happening, your life is so much easier and their outcomes are so good. So we had a horrible problem with CMV, ganciclovir resistance at the UW. And, these patients had very long lengths of stay. Their grafts outcomes are horrible because the drugs are incredibly toxic, foscarnet. We had someone go blind from cidofovir. I mean, horrible. So throughout the years of doing QI and trying to evaluate our stewardship program, we've really tried to drill down to, how can we prevent every bad thing from happening? And obviously, you can't prevent everything, but I do feel like the proactive approach with the monitoring of the high risk group, because if you're going to have problems, it's going to be in those patients, your seropositive patients, they have pre-existing immunity, which they can reconstitute. But the high risk people are the ones to keep the eyes on. So.
Yeah. And on that note, I'll mention that, one of the things that I was most interested in, as I said before, as the clinical trial of using letermovir as prophylaxis in high-risk patients was, would we see resistance? Because you will see that if you give it to people with already resistant or refractory disease, or people who aren't tolerating other agents. And it wasn't observed. It was observed with valganciclovir, and that was probably because the drug had to be stopped, or I doubt it was dose reduced in the clinical trial, and you had high levels of replication. So we're getting near the end of the program, and I want to go through these goals. So I want to thank the audience for their participation today, and I want to summarize these SMART goals, which stand for specific, measurable, attainable, relevant, and timely. And so our goals today were to identify the prevalence, burden, and risk associated with CMV in kidney transplant patients, to utilize scientific knowledge and clinical data of both novel and historically used medications in prophylaxis of CMV in patients with kidney transplants, and to implement specialist guidance and perspectives in the development of CMV prophylaxis at your institutions. And finally, to receive credit, you can see that there'll be a post-test and evaluation online. And I want to thank both Dr. Jorgensen and Dr. Bloom. I really enjoyed learning from both of you and discussing this issue. And again, thank CMV Outfitters for arranging this program. And thank you again for joining us, and be safe and take care.